Hey, everybody, welcome back to the podcast. Well, I've been wanting to do this episode for a very long time, and I know you guys are going to love it because I just finished reading his book, and I think it's a book that every single woman has to go out and get. Same with every doctor, actually, as well. But my guest today is Dr. Mache Seibel. He is a Harvard Medical School faculty member. He's the author of two best-selling books, The Estrogen Window and The Estrogen Fix. Dr. Seibel helps women feel better and look better in midlife and beyond. He is also editor and founding publisher of the #1 digital magazine for midlife women called The Hot Years, which I love. That's such a great name. Before transitioning his career to focus on menopause, Dr. Mache was a leading expert in infertility, performed some of the first in vitro fertilization successes in the United States. Dr. Mache has published over 200 scientific articles and 17 books for both professionals and consumers, and has received multiple national awards for patient education, research, and innovation. He is board certified in gynecology and reproductive medicine and a NAMS certified menopause practitioner. In addition to seeing patients in his office, Dr. Mache is a sought-after speaker, consultant, and menopause coach at menopausecoaching.com. So welcome, Dr. Mache.
I can't tell you how much I was looking forward to this, and I'm delighted to share some information with you and with your audience.
For my own personal, this was a very personal podcast interview for me because at the ripe old age of 43, I slammed into perimenopause, and my estrogen took a complete dive. I look like I should be in menopause when you look at my labs. And so in the last few years, I've just been digging into the research of estrogen because, like so many women, I too was afraid. Even though this is what I teach, this is what I research constantly, it was still one of these, I stayed away from the estrogen. I was like, nope, let's stick with the bioidentical progesterone. But we have been so misinformed. But let's back up. I want to hear.
May I make one comment about what you just said?
Yeah.
You know, a lot of people equate menopause with being older.
Yes.
And one of the problems is that many women see menopause as just meaning that they're old and they're going to be, at such a different place. So it has a very negative connotation.
Yeah.
But between 5 and 10% of women are actually going into menopause by age 45. And 1 in 100 goes into menopause before age 40. That's called premature menopause because it's so early. And there's separate issues for health for the younger women for the women who go into an earlier age. But I think we have to start changing the conversation from menopause as being about age and rather thinking about it as being about transition, because that's really what it is. Just like puberty transitioned girls into women, perimenopause, which is the years leading up to menopause and can last up to 10 years, is the transition that leads women from reproduction into post-reproduction. And it's a transition that can occur at any age. And since the symptoms can start up to 10 years before menopause, there's a lot of women, such as yourself, who are having symptoms in their early 40s or even their late 30s, and they figure, well, it can't be that.
Yeah.
But it could.
And it just shocks me, though, how many women have no idea that it's hormones. Like, they'll hear me speak on another podcast and it makes them go, oh my gosh, I'm 42, but could this be my hormones then? Because they hear me talking about symptoms of hormone dysfunction. And there's so many women that are like, am I in perimenopause? And I'm like, yeah, probably. It's shocking. Do you think that there's more and more younger women? Do you see more and more younger women as the years go on? In that sense, just of our environment.
There are environmental challenges. Women who smoke go into menopause earlier. Women who are, in certain environmental toxins that can cause damage to the ovaries. Women who have certain conditions like endometriosis, which is a condition where the lining of the uterus goes outside of the uterus, kind of menstruates internally and gets stuck onto the ovaries and causes destruction of the ovaries. And of course, now we have this awareness of genetic diseases. So we have about 2 million women that have the BRCA or breast cancer gene, and they are having to deal with going in and having their ovaries removed, many of them in their 30s, maybe 35, at latest 40. And suddenly, wham, they go right into menopause. And if you go in gradually, it's kind of like symptoms kind of ease up on you. But when you go in, like having your ovaries removed from a normally menstruating woman, it's very much more powerful impact because you go from normal levels of estrogen down to postmenopausal levels. So there's all these genetically motivated surgeries that are throwing women into early menopause. And all of these women have their challenges.
Mhm. And, I just want our listeners to know your background because you didn't just come out of this like, oh, yeah, I'm going to talk about estrogen. Like you had a personal thing with your wife and
Right.
you were a doctor and you have done your due diligence on the research. I mean, you researched this for 10 years. I mean, you have not taken this lightly. So you are such the expert on this and you're really trying to educate women. So I'd love for you just to give us a little background on how you got into being the menopause guy.
Well, it is a very personal story, and thank you for asking. Um, as you said, my original area of expertise was in the infertility arena, and I had the opportunity to do some of the first IVF procedures in the country, and was going about my business doing that when my wife had surgery because she had the BRCA gene and
Mm.
had to have surgery that threw her into early menopause. Unfortunately for her, she was having this surgery only about 7 months after the famous Women's Health Initiative study, the WHI study, that incorrectly stated that estrogen caused breast cancer and heart disease. That has been disproven, and we can talk about that.
Yes, we're going to
But
talk about it.
she was right after that study, and nobody wanted to treat her.
Mm.
And so I say I used to do sperm to term, now
Yeah.
I do womb to tomb, because I had to transition as she did, because I had to figure it out so she wouldn't have to tough it out. Because there she was, and being told not to go on hormones, and she was miserable. And that didn't seem right, especially if there was a way to look at the data and understand it more correctly.
Mhm. I know, that's amazing. You saved your wife and now millions of other women, which is, I think, pretty cool.
Well, I'm very dedicated to this because I know what
Yeah.
goes up in personal, what it does to people. And I think there's no reason for women to suffer. They don't have to.
Hmm. So
And
give
even
us,
if they can't take hormones, and I want to say, even if they
yeah.
can't take hormones, there are other options for them. But hormones are safe for the majority of women, and they should understand that if they are a candidate for it or not.
Yes. And so let's understand the history because I think it's like speaking to women like myself, the only reason why I knew about the WHI study was because I researched hormones. But a lot of my listeners that are in between the ages of 40 and 50, they were actually too young to even like I
Right.
never heard about that in the headlines. And for women over 50, maybe you guys have, but what happened? Because in the 1960s, estrogen replacement therapy was the number one prescribed hormone in the drug in the United States.
Yes, it was. It was
That's crazy.
the number one medication in the United States. And, there was, like all things, they realized at some point in time, hormones were not even invented in terms of prescriptions until the 40s. And then they realized shortly after that that by giving it to women in menopause, it did away with their symptoms. They didn't know how much to give. They didn't know how long to give it. There was a lot of, in the beginning. But what happened was there had never been a study to prove safety. And so there was a huge study with tens of thousands of women called the Women's Health Initiative. And in it, it was divided into two parts. There are women who have a uterus because they have had no surgery to remove it. And there are women who have no uterus because they had a hysterectomy. They had their uterus removed, just for whatever reasons that was. And the first study was for women with a uterus. And those women were given estrogen and progesterone. Both medications are needed if you have a uterus to protect the uterine lining and to give you the symptom-free experience. What happened was, in order to recruit women, the study was for women who were between the ages of 50 and 79. So that 50 to 79 is a big range.
Yeah.
Well, it turns out that there were so many women already on hormones, they couldn't find any women who were in the younger end. So 75% of the women in that first study were in their 60s and 70s. Whereas 75% of the women who got the sugar pill, the placebo, were in their 50s. So the study ended up overwhelmingly comparing healthy 50-year-olds to women in their 60s and 70s who got the medicine. So placebo in the 50s, medicine in the 60s and 70s. And because they had such a hard time finding women, they bent the rules a little. It was supposed to be a well-woman study, but many of the women in the study were smokers, they were overweight, they had diabetes, they had high blood pressure. And so all of those are risk factors for heart disease and some for breast cancer. And so as a result, they had older women with high blood pressure, diabetes, smokers, and they were comparing them to young, healthy women. And then it was like almost a decade later when they took the women and then compared in the same study. They just simply re-looked at it by age. And when they looked at it and they had everybody in their 50s, whether you took the hormones or you didn't take the hormones, almost everything went away. All the problems, the breast cancer, the stroke, the heart disease, almost everything was completely disappeared. And that's why there is an opportune time when you're younger that you can take hormones more safely, and a more risky time when you're older to start taking it, because while you weren't taking hormones, your body was aging. And while it was aging, it was laying down plaque in your arteries and setting up the risk factors that put women at more risk for these other medical conditions. And of course, women who go into menopause younger, they need to start sooner. They need to start when they go into menopause, even if it's in their 30s. I have some women through the years that come to me, I've seen in menopause in their 20s. They had various genetic conditions, not the kind that cause breast cancer, but the kind that turns the ovary off, or other things that happen. And so as a result, they're in very young ages when they start going into menopause. And those women benefit greatly by starting their hormones at an earlier age, because it cuts away some of the risk for heart disease. It actually lowers the risk for psychiatric conditions and depression and bone loss and a whole host of other things.
Yeah. What I love about your book too is like you go through all the major killers of women: heart disease, diabetes, Alzheimer's, dementia. And then when you start to look at all the major killers of women as we age, that's the ticket there, is as we age, all of these things start to show up. And as we age, what happens? We lose our hormones. And so there's this direct correlation between losing our hormones. I always say, if you look at it from a biological standpoint, we are no longer, once we can't have kids, we are no longer good. We're not going to be contributing to the tribe anymore, to the human race anymore. What good are we? Get rid of us. Let's kill us off, right? Because we can't reproduce
No,
anymore.
I don't think that's quite that's not the message I want to send here.
No, I'm just saying that
Well,
that's like our hormones start to go down, and
right.
possibly if we looked at it from like a hunter-gatherer standpoint, why did that happen? And maybe that is what kills us in a sense, is that depletion of hormones. Now we don't
Well, the
anymore
lack
because
of
we're
hormones
in it.
sets the stage for some very major
Yeah.
health issues. But remember, up until 1900, the average age of death was about 51.
Hmm.
So most women didn't live to go into a long postmenopausal time. The majority, of course, some women live to be longer, some men live to be longer, older, but in general, people were dying much earlier. And of course, our purpose in life, really, from a biologic point of view, is to reproduce.
To
Whether you're,
reproduce.
at the lower end of the animal spectrum or the upper end of the animal spectrum, which humans are the top of it, our goal is to have children and to reproduce and to replace ourselves. And that's how the species continues. So people just didn't live on. But now, of course, with better nutrition and antibiotics and, the basic healthcare improvements that have happened, people are living to be, now a woman lives a third of her life after menopause. And so we have to really understand how to take care of ourselves so that we can not only live longer, but live better for the longest amount of time.
Yeah, and not suffer, because so many women feel like they have to put up with these symptoms and suffer through it, and they're nervous to take the hormone replacement. So let's talk about what the window looks like. Like, what are we talking
Okay.
here as far as the estrogen window goes?
Well, the best time, the most safe time, the most opportune time for people, for women to take hormones is beginning as close to menopause as they can. So what we have learned is that the age to take hormones, the optimal age, is like between 50 and 59. That's the most opportune time to begin them. It doesn't mean you absolutely must end them. It means you best begin them in that window for safety's sake. Now, if you're a woman who goes into menopause, as I alluded to earlier, in your 30s, your 40s, then you start the hormones at that time and continue them up till the natural menopause age, which is on average in the United States about 51 years old is the average age of menopause. But remember, there's
It can vary.
it varies. So people go normally into menopause. They naturally will go into menopause from 45 to 55. And occasionally I see women who don't go into menopause until they're nearly 60. So as I said, it's all about transition, not about age. But on the other end, there's some that go much younger. So the trick is to begin as close to the onset of menopause as you can, or you're comfortable with, and continue it until the natural mean of menopause, which is about age 51. Now, you can go further. I'm not saying you must stop there, but I'm saying if you begin earlier with menopause, continuing it through the natural age of menopause, at least that long, takes away a lot of the risk for conditions that would come later.
Right. Now, what about for women like myself, is who I have very low estrogen and I'm only 44. I still have a period. It's irregular, but now that I've started taking hormones, it's getting a lot better. Is it okay then, if you're still cycling, to begin the estrogen if you know on your blood work, your saliva, whatever hormone test you do, that it is actually low? Is it safe to take it at a younger age?
Well, when you think about safety, think about how many women are on birth control pills.
Yeah.
It's now probably birth control pills is the number one medication in the country. I
Yeah.
mean, it's so prevalent. And those pills are a higher level of hormones than hormone replacement therapy. So if we take them when we're younger, then the safety seems to be quite fine. And, there's no reason for a woman to suffer when she's in her early 40s if a little boost of hormones can just simply elevate the level. Many times it's not about all or none, it's getting enough to minimize symptoms.
Yes. Yeah. And I think that that's important to hear, is there's not this like magical dose. It's, you use it at the smallest dose and you work your way up till you are symptom free. And that dose may change over the years.
It's not going to may change. Dosages always change
Always change.
because people are always changing. what happens is that you don't have to have all symptoms go away to have enough. Let's just say a woman were having such disrupted sleep from hot flashes, or she was in the front of office meetings, or conducting things and doing interviews as you are, or some other things, and she started having hot flashes and sweating and so forth. Well, that would be embarrassing. It would be awkward. It would be uncomfortable. It would be unpleasant. So many times women are content to deal with a lower dose that just gets to the threshold of where most of their symptoms are dealt with. And if they have the occasional minor this or that, it's okay. Remember that hormones, when you begin to go from the reproductive years, in those years, the hormones estrogen and progesterone are finely balanced. They're going in a very predictable way, like paired figure skaters. But what happens is when you get closer to menopause, just like when you were going through puberty, hormones are just doing their own thing. And when that happens, the imbalance is what causes so many of the symptoms, the mood changes, the anxiety, the sadness, the palpitations in the chest, the just poor sleep and so forth. It's the imbalance as much as it is the actual absolute amount. So what happens is, as you get closer to menopause, the imbalance will get greater and greater and greater, and the symptoms will get more. And then eventually you get to the other side of it, and all the levels come down to low, and they're no longer in balance. They're at a low place, and some hormone would make life more comfortable, but you get away from all of that constant change in the PMS feeling and just not feeling quite right. Like who inhabited my body
Yeah.
type.
Well, I've had men tell me that they don't even know who their wife is anymore, or if they've been through it, they say, "Oh my goodness, I didn't know if I was going to survive those years of my wife going through menopause, because she became somebody completely different." And it's just, you
Oh,
don't need to suffer.
there's a lot of a lot of marital discord that happens for some couples during menopause, and it happens a lot too with loss of libido.
Yeah.
And what will
Yeah.
happen is, as the estrogen levels lower, not only does it affect mood and so forth, but just like there's changes in the skin, there's also changes in the tissues of the vaginal canal. And when that happens, the tissues can start to get narrower and shorter and drier. And that dryness causes a lot of discomfort. It's one of the most common conditions, and yet it's the real don't ask, don't tell thing.
Hmm.
Women go to their doctors for a long time, and if the doctor doesn't ask, and most don't, the women don't tell. And because of that, this very painful condition is affecting at least 55, 60% of women, and yet only 7%, that's 7%, are getting treated because they're not asking. And the doctors aren't asking, the patients aren't telling, the doctors aren't asking. And what happens is the husbands are afraid they're going to hurt somebody, so they don't want to do anything because they think that, oh my God, I'm hurting her. And she would rather be shopping than deal with it because it is hurting her. And
Yes.
so what happens is you get a lot of discord, and people will say, oh, my husband's so understanding and so forth. Well, that's good, but you don't have to have that problem, because the nice thing about this timing of estrogen is the window of opportunity to make it better doesn't close in the vagina. In other words, even if you're an older woman and you're having difficulty in that area, the dryness, the discomfort, and so forth, that can be treated locally. And the thing is that when you look at the fear factor about hormones, the women are afraid they're going to get breast cancer, etc. I
Yeah.
understand the fear. It isn't valid, but it's there. And the fact of the matter is that there is a black box, the warning box on vaginal estrogen, that says taking hormones can cause breast cancer and blood clots and everything. FDA has never removed that black box, even though the data has changed. Now, what happens is that in a study that came out, a report that came out from the American College of Obstetricians and Gynecologists just a few years ago, they looked at vaginal estrogen and they said, is it safe for women? And they found that even in women with estrogen receptor positive breast cancer, vaginal estrogen did not increase the risk of either recurrence or death in those women. So there's really very little reason, particularly if you've already tried the over-the-counter stuff and you've tried other stuff and it doesn't work, you shouldn't be afraid to ask your doctor for some local hormone therapy, because it is true that what goes in the vagina may not stay in the vagina. In other words, a fraction of it will get into the bloodstream. But that isn't sufficient to cause the problems, because they've studied thousands and thousands of women who have done that, and they know there's no increased risk of either death or recurrence. And so you shouldn't suffer, and particularly for women who have had breast cancer, which there are far too many, but still, those women in particular have a certain almost level of guilt sometimes asking about their sex drive and their sex life, because they feel, I should be grateful I'm alive, I'm living. Oh, hell, I can deal with that. Well, you don't have to deal with that. And even if you won't take hormones, there are many other prescription medications and other choices for you. I mean, if you have a symptom, you should know that there's probably a solution for it. If it
Yes.
can't make it go completely away, it can make it get better. And you just have to talk about it. You have to be willing to say something, and don't wait till the last minute of your exam when you go in and you're about to leave and the doctor's already got the hand on the door about to leave. Start talking about that at the start of your visit. And if there isn't time in your visit to talk about it, then say, you know what, this is really important to me. Can I make another appointment to come back and talk about this so I can get some help, because it's really messing with my life. And if they can't help you with that or other issues, then for those issues, you need to ask for a referral to who can help me. Doesn't mean you have a bad doctor. It means that may not be one of the things that they are really good at. And so they shy away from it with you.
Yeah.
But that's okay. You just ask, who can help me? And then you get an answer.
I had one woman who thought she had had a chronic yeast infection for 2 years because her vulva was constantly on fire and itchy and dry. And when she came to see me, I said, I can't remember what the name of what it's called. You probably know, but I said, I think this is estrogen deficiency. And I said, you need to go ask your doctor for a vaginal suppository of estrogen. And she did. And like 24 hours later, it was back to normal again. She went completely away.
Well, it won't be normal 24 hours, but
I don't know. It was quick though.
Yeah. Because what happens is biologically is, in order for a baby to come out of the vagina, I mean, that's a big object coming through a small opening. And the reason that works is because the tissues are corrugated. In other words, they have these folds and very elastic. So the vagina can actually distend to let the baby out and then go back to normal. But with hormone loss, those folds go away and the walls get rigid and they get drier and shorter. And because of that, it can crack and it can't distend. And so what happens is that during relations, it hurts because it's dry and because it doesn't stretch at all. But all of these things have solutions. So just don't be afraid. And you gave the lady some really good advice, and it's good that she could get help.
Well, and she'd been using all these products to get rid of a yeast infection, and it was estrogen. And I know that the lack of estrogen can also cause incontinence in women as they age. So they're peeing their pants easily. And that can be also remedied with estrogen. So there's so many things, and it's preventative of, and you go through all of this in your book, but Alzheimer's and heart disease and the breast cancer thing. So if somebody has the genetic, if she's had estrogen driven breast cancer, or she's got the genes for it, is it still safe then to take estrogen?
Okay, well, those are two questions.
Okay.
So let me divide them up. If it's an estrogen-driven breast cancer, Most doctors will be reluctant to offer estrogen to that woman for after treatment. Although I must say that I have a very small handful of women who have small enough degree of cancer, have been treated and are far enough out that I will start them on estrogen. It's a subset, it's very patient specific. And that's because with their consent, they understand that the quality of their life is sufficiently compromised that it's not really living for them. So, but usually that doesn't happen. So let's just say if it's an estrogen type cancer, most women will not get estrogen, and there are other options for them. On the other hand, if you have one of these BRCA genes, which is a breast cancer gene, and you have your ovaries out to lower your risk of breast cancer, and I should say it's the ovaries and the fallopian tubes out, because most ovarian cancer actually starts in the fallopian tubes, that little tube that takes the egg from the ovary into the uterus. Those women do not have a problem taking estrogen. In other words, if you have BRCA gene and you get estrogen after your ovaries are out, you do not increase your risk of breast cancer greater than the increased risk from having the gene in the first place. So they can take it. And there's a lot of doctors that won't give it to them, but there's definitely good data on this. And there's no reason for those women to be 35 years old or 38 years old and be taken and put into menopause and then suffer for another 50 years. I mean, there is just no basis for that.
No. And didn't they used to treat certain breast cancer with estrogen? And I've
That
heard of a leading oncologist in the States, I'm not going to remember his name, but who is doing it right now.
Yes, as a matter of fact, estrogen was a treatment for breast cancer. It's probably 40 years ago,
Mhm.
but they gave it, and they gave it in very high dosages, and it actually improved breast cancer. There were some other issues because the dosages that they chose had some effect on the kidneys, and so they stopped using it, but it was actually treating breast cancer, and you're quite right. But now there's better and more specific treatments. And fortunately for women, if they get diagnosed at a relatively early stage or earlier in the disease, there's so many treatments now that women don't have to assume that they're going to die from breast cancer. Matter of fact, the vast majority of women are going to uh, be survivors of breast cancer.
Yeah. And so that's great. So that's good to know, because I think that's probably the biggest fear of when it comes to taking hormones. It's the first thing I always hear. Well, is it going to cause breast cancer? And so I think that that's something that every person should talk to their doctor about and see if
Right.
it's a good fit for you, but to know that it can help prevent breast cancer. So
It's interesting for women who have had a hysterectomy and they don't have a uterus, they only have to take estrogen. In other words, they don't need to take progesterone. The progesterone, the progesterone means progestation. So progesterone is there to help the fertilized egg implant in the uterus. So women who don't have a uterus don't need progesterone, only estrogen. And for the women who start estrogen in their early part of menopause, as soon as they hit menopause, and take estrogen only, they actually have a lower risk of breast cancer than the women who take the placebo. It actually lowers the risk of breast cancer.
yeah.
For those who take estrogen and progesterone together, there's either no risk increase, or the increase is about the same as if you drank a glass of alcohol a few times a week, which does have a minimal increase, like a couple glasses of wine a week, or if you have dense breasts, because that is also a risk factor. But taking estrogen, progesterone is no greater than those naturally occurring circumstances.
hmm And the Women's Health Initiative, it really, like, the results showed, people thought it was the Premarin, just the straight estrogen, that was causing the issues, but it wasn't it that the results actually showed that it was the combination with the synthetic progesterone, the progestins, that was
Yeah,
the problem.
you're so right. At the time that study was started, which was in the late 1990s, the only oral progesterone wasn't really progesterone. It was a synthetic progestin. Something that acts like progesterone but isn't one is called a progestin. That's just a term for all um, progesterone-like medications, but not progesterone. And the progestin that they used was medroxyprogesterone or Provera. That's the brand name. Medroxyprogesterone is the generic name. That's the culprit. And in fact, if women go on whether it's Premarin, which is a synthetic estrogen, or they use a bioidentical estrogen and they use a bioidentical progesterone. Either way, if they use that combination, has very little impact on breast cancer risk if it started earlier in menopause.
Mm-hmm. Yeah, it's the combination of the estrogen with a bioidentical progesterone that is the safe combo, not the
Right.
synthetic progestins. I think that's good to be clear about that one.
Also, I want to say, if I may, that
Yeah.
about bioidentical. There's a lot of confusion about bioidentical because people generally think that bioidentical hormones only come from a compounding pharmacy, and the other kinds of the chain drugstores, the Eckerd, Rite Aid, CVS, Walgreens, all those other ones, they have only synthetic ones. That isn't true. In fact, bioidentical ones are available in all drugstores. But the ones in the chain drugstores come from pharmaceutical companies, and they are FDA approved, meaning they have to have very specific specs and testing. What we find is, in one study that was done in the bioidenticals that are coming from compounding drugstores, is they gave a prescription for an estrogen and progesterone. They had it filled at 12 different drugstores, compounding drugstores, and then they gathered up those filled prescriptions and they took them to a chemical laboratory to analyze what was in it. And what they found is that, in fact, the amount of estrogen in them in general was between 80 and 150% more than what the prescription was actually written for. And the progesterone was actually about 60 to 80% lower. So this made a much higher estrogen than prescribed and a much lower progesterone. And there are some women who are getting now a uterine cancer because the estrogen is high and the progesterone isn't high enough to protect it, because it's all about balance. Mm-hmm. And so if you are getting your hormones from a compounded drugstore, it can be fine for you, but who's ever taking care of you has to check your uterine lining periodically, once a year, every other year, some interval of time, by a variety of different tests to make sure that the lining is not changing to something that's harmful to you. And that's totally preventable. You just have to have it checked.
Yeah, that's a good thing to bring up. It's with an ultrasound, isn't it, when they check the uterine lining?
There are several ways. You can do an ultrasound and see how thick the lining is. If it's very thin, then you know it can't be building up to a cancerous or precancerous level. So you want it to be down like 4 millimeters or less. But you can also, in an office test, you can go into and do what's called an endometrial biopsy. It is the lining of the uterus is called the endometrium. And so there's a little instrument that's about that big around, and I'm talking about that part right there, just very small, and it inserts into the uterus and pulls out, it scrapes just a few cells out, and those are sent to a pathologist to look at directly. It causes a mild cramp, but that cramp is gone in about 5 or 10 minutes. Mm-hmm. And so one of those things are the most usual ways to test.
Okay, good to know. And in Canada, we can't buy any even bioidentical hormones over the counter. like you guys can in the States. I know that you can buy progesterone, DHEA, pregnenolone, but I
You
don't,
can't
and
buy any.
estriol, but can you buy estradiol?
You can't buy it in the United States except on the internet. You can buy a type of progesterone that has been around since the 1970s, right before the law came in, and it got grandfathered in. But it is a homeopathic dose, meaning it's really, really low. It's probably too low to be of any real benefit. It's certainly for protecting the uterine lining, but it is
Mhm.
sold. But you can buy DHEA over the counter in certain dosages, but you can't buy estrogen and progesterone over the counter or in stores here. You have to have a prescription for it, just like in Canada.
Mhm. Which is good because then you know what you're getting for the most part if you're going with a reliable source, right? Because there's
Right.
some that are on there that aren't very reliable sources. So I think it's good to try to go through your doctors. Just some people find that they're met with resistance, especially younger women. Younger women will go in and say, look, I think I'm going through perimenopause. And their doctor says, no, that's not possible. You're too young. And so they're left to suffer.
They are. I'll tell you, I see a lot of women either in my practice or as in coaching. I see women that have been to half a dozen doctors or certainly to two or three. And what happens is they have a mood thing. They go to the psychiatrist. They have palpitations. They go see a cardiologist. They have different kinds of things, and they're going one doctor for one for the other, and it's all under one umbrella. And even so, many doctors are reluctant to give hormones. I know it's unfortunate, but as went on my book tour around the country, I gave talks all across the United States. And I spoke to people, and in every audience, there would be people who were fearful of taking hormones, and their doctors wouldn't give it to them. Even if they wanted it, they couldn't get
Mhm.
it. And that's because it's still not been clarified to the medical community that the data have changed. And so it's just a matter of making sure that you advocate to get your symptoms taken care of, because you really don't have to suffer.
No, I know my compounding pharmacy told me that they will not give, like whenever somebody or gets on estrogen, they will make it so that it's 80% estriol, not, and then only 20% estradiol. And the stuff that you're talking about is you're talking straight estradiol, which is another form of estrogen, correct?
Right. There are three kinds of estrogens for the most part: E1, E2, and E3. E2 is the estradiol. It's di, two alcohol uh, on the end, two alcohol particles on the end. But the point is that the dominant one of the ovary is the E2 or estradiol. Estriol, which they also put in sometimes in compounding pharmacies, is only in the woman during pregnancy. It comes primarily from the placenta and from the pregnancy. And so it's not really one that's needed. And the the bioidentical ones that you buy in compounding pharmacies are often combinations of estrone, which is E1, and estradiol, which is E2. But estradiol takes care of all of the symptoms.
Yeah, I just thought it was funny that he thought he was doing me this great favor. He's like, oh, it's 80% estriol and only 20% estradiol. He had no estrone in it, but he was trying to reassure me. And now I know better. And so I'm going to have to try and get him to change it. But it's just interesting because, like everybody else, there's a fear around it. And I know my doctor even told my mom, oh, I can't give you estradiol because you're on estriol. She had the vagina ring inside of
Mhm.
for the vagina lubrication part of it, which a lot of women
Mhm.
get. But she said she can't do both at the same time. I was like, no, you can.
Yeah, you can, because there are two kinds of rings that go in the vaginal tissues. They're like diaphragms, if you're familiar with the diaphragm. They're kind of a circular, uh, flexible ring, and they have hormones inside the ring. And when you insert them, one kind is a low dose that's only for local. And so it goes in, you can keep it in for months at a time. And there's another one that goes in that has a higher dose. And that one is for, that's like taking your estrogen vaginally. Like you can take it orally, you can take it topically through a patch or a cream or a gel, and you can take it vaginally through the vaginal canal. There are many ways to take it. I do want to say, though, that although we're talking a lot about estrogen, I do want to say that I'm not in any way, mandating anybody I talk to take estrogen. I'm only interested in those who would benefit and who want it, understand that it's an option for most of the women that can't get it or aren't taking it. But there are many prescription medications out there now and non-prescription options and even lifestyle changes that women can do. The point is, even if you can't take estrogen, even if you're way outside of your estrogen window and it's no longer the best choice maybe for you, don't deal with your symptoms assuming there's nothing that you can do, because there are many things that you can do. You just need the right information so that you can incorporate that into your life. And the most important thing is don't suffer needlessly. There's something for everyone to at least try. And if it can't make it go away completely, it can make it better.
Yeah, there's some amazing supplements. Is there any one that's kind of a favorite of yours that's like a supplementation to help with the symptoms?
Well, it depends on what it is the symptoms are, because the benefit of one benefit of hormones is that if you have, the foggy thoughts, or you have the skin, you want to keep your skin looking better, or you want to have, or you're having hot flashes, or whatever it is, hormones will go to every cell in the body. If you are someone who is not taking hormones, then you have to really think, I need to take care of the sum of me and not just some of me. And it's very important to realize you want to protect your bones, because if you're a healthy 50-year-old woman, you may be worrying about breast cancer, but your risk of dying of a complication of a broken hip or some other complication of osteoporosis or thinning bones is the same as it is of dying of breast cancer. So you want to protect your bone health. And so you have to take something for your bones. Estrogen would be doing that for you, but if you're not taking it, you have to address it. If you want to take care of hot flashes, then that's another type of supplement or another type of medication. If you want to deal with the vaginal dryness, that's a different one that you have to do. If it's bladder sensitivity, then that's another one. And so you have to realize that you have to work with someone to take care of the sum of you. A lot of the common ones that are used for over-the-counter products are things like soy, which is, I have a whole book that I wrote on soy, The Soy Solution for Menopause. There's a lot of things you can do with soy in terms of maintaining bone and maintaining hot flashes. It doesn't take away all the hot flashes, but it can lower them about 30 to 45%, which sometimes is enough to help you sleep through the night. And so that might be helpful. Black cohosh is another one that's very common. Flaxseed is another one that's very common. There are a number of over-the-counter products that have benefit for hot flashes, which is what I call a noisy symptom. I divide women's symptoms into noisy ones, which are the hot flashes, the mood changes, the things that you really know are going on, and the silent ones. The silent ones are really the ones that will kill you. That's the heart disease. That's the breaking of bone,
Alzheimer's.
Yeah, Alzheimer's. Those are the silent ones that sneak up on you. And so you have to realize that while you're addressing this hot flash, which the fire is burning, you want to put that out. But while that is going on, inside there are other things going on. And so the sum of you has to be taken care of. And to do that, you have to be looked at very holistically.
Yeah. So if a woman's in her 60s, so it's kind of opposite of starting young, if a woman's in her 60s and she's got she hasn't had her period. She's been in menopause for 10 years. She doesn't, she's well through it, but she's getting memory problems. She's getting hot flashes. And I have some women like this. Does somebody like that, do they try it and see if it does help them out, even though they're past the window?
It depends.
Mm-hmm.
It gets very individualized. If a woman has been on estrogen from the time that she went into menopause and hit 60, that woman could potentially, and I have to say this is caveat, it depends on the
Mm-hmm.
woman, but that woman would be the candidate that could potentially continue
Keep
on
going.
it further. If a woman didn't start it over here and now she's over at this end of menopause, she's now 60 or 65 and she wants to start now, then you have to really individualize because there could be more risk in hormones at that time. But then you start to get in, most women will not just suddenly start having hot flashes at 60. They generally have them starting earlier, although it's possible. And you have to remember that hot flashes could be due to something other than menopause. It could be to a medicine that you're taking, could be to an infection. It could be to a number of other things, and that's a separate workup that needs to be looked at. But lifestyle things make a difference. One of the most effective ones is exercise. I mean, the things your mother told you: eat healthy,
Don't
exercise,
smoke, don't
get
drink.
enough sleep, lower your stress. I mean, today we're in a very stressful world, and that stress is just compounding every symptom that we have, no matter what it is. And it's hard to sleep. Everyone's very anxious right now. Jobs are being affected. The can't visit with your daughter who's pregnant. You can't go see your mother in in an elder care facility. I mean, everything is disrupted. And so there's so much extra stress that is being added on to our society. But
Mm-hmm.
lifestyle changes like exercise, eating healthy foods, avoiding processed foods, sugar, getting enough sleep, doing things like cognitive behavioral therapy, or CBT, which is kind of a form of hypnosis, has been the best studied of the lifestyle. And can be very helpful for lowering the symptoms of mood, of lowering the symptoms of poor sleep, of lowering the symptoms of hot flashes. This is a very powerful tool. It has to be taught by someone who's specifically trained in it, but that can be effective. Then there are specific medications that are non-hormonal for bone health. There's a specific one now. There's one for hot flashes. There's going to be a new medication coming out for hot flashes that's just come out. It's an injectable one. It's not hormones, and it affects the release of a certain peptide, a protein in the brain that is believed to be where the source of the hot flashes are. And so you'll
Wow.
start to hear and see more about that. But there are things you can be doing, no question about it.
Yep, absolutely. So before I let you go, one very big question. Does it help with weight loss? Because we all know when you hit perimenopause, you all put on the 10, 15, 20 pounds around your waistline, and it has a lot to do with estrogen going down. So does taking estrogen, can it help with weight loss? It's the $1 million question.
Yeah, well, let me just say that if you want to, if you wanted to a weight loss pill, estrogen isn't a weight loss pill. Having said that, though, estrogen, what we know from the Women's Health Initiative is two things that are very important here that have to do with weight. One of the biggest issues, particularly for women, but for men too, is diabetes, type 2 diabetes. And we know that the women who took hormones ended up with less diabetes than the women who didn't. In all the studies, whether it was estrogen and progesterone or whether it was estrogen only, women who have hormone therapy have a lower risk of diabetes type 2 than women who don't. And they do particularly better with patches than they do with oral in terms of diabetes. But the other thing is that estrogen is very helpful in stopping the redistribution of fat. Because what happens, sometimes your weight doesn't change, but all of a sudden you got a muffin top
Mm-hmm.
and it just seems to find its way down there.
Yeah.
So estrogen helps prevent the redistribution of fat in the body. And so even though women think if they take hormones, they're going to gain weight, there's a lot of myths about that. But on studies that have specifically looked at that, that isn't the case. Now, some women may have a little bit of bloating or something depending on the dosing, fluid retention, things like that. But as terms of the fat on their body, it is helpful in controlling weight. But I wouldn't want to tell you it is, a diet pill.
No.
We simply have to realize that every decade we age, we consume metabolically 3% fewer calories. And so it's important that we adjust our diet as we get older, that we realize that just because we are older doesn't mean we can't do exercising. You can do a lot of exercising and you don't need a gym or anything. Your arms will get pretty heavy if you hold them up a while, and your legs will get heavy if you lay on your back and hold them up a while. And you'd be amazed how many exercises that you can do with almost nothing.
Yeah.
And help to burn calories and stay in shape. But it's important that we keep that going. I'm walking now about 4 miles every day. And I just, if I can't go outside, I'll just walk around the house. I mean, that's really, I'll just keep walking because I got to get in my exercise. So it's very important to incorporate. And what you realize is that age requires us to have habits that are healthy. And we can't cram for life. You just can't. You can't exercise one weekend and suddenly be fit.
Yeah.
You've got to do a little bit every day. Just carve out 15 minutes. If you can't walk around the block, walk to the corner. If you can walk to the corner, walk halfway around the block. That's a sneaky one because you got to walk back. So I got you all the way around the block that way. And so you just keep doing little bits and increasing it each week a little bit more. Mm-hmm. And the most important thing is you've got to get a splint for your elbow, because if you can't keep doing this, it's going to help. And a lot of us, when we're stressed and nervous, we're eating constantly. Yeah. You go and you find you're just nervous and you just want to put something in your mouth just to chew on, and you have to keep the meals constant, keep the quality of the food that you eat, healthy types of foods. And if you're going to take a snack, try and get something like eat on a carrot stick, or try and get some hummus and celery, and try to keep the processed food out of your house. I mean, you just got to change your habits and make healthy ones for the rest of your life.
Absolutely. So you guys got to get the book. It's just something that every woman needs to educate themselves on, because I don't think that you're going to find the information anywhere else. I mean, we've only scratched the surface in this podcast today. So it's the Estrogen Fix, or the Estrogen Window. And you can find Dr. Mache at menopausecoaching.com. And you actually do private coaching sessions with people all over the world, so people can get that one-on-one help if they need it.
Yes, I do, because it's hard all over the place to find information. It really is.
It really is.
It's always a pleasure to talk to people and see if you can help them.
Yeah. Well, thank you so much for coming on the show. It's everything I wanted it to be and more. So thank you.
Well, I really appreciate being included. Thank you so much.